Thank you, sir, for such an informative session. Now switching from endocrine to neurosurgery, our second talk is the neurosurgical perspective of pituitary guidelines. And for this, I will invite Dr. Ather Enam. He's Tara Imtiaz, the professor of neurosurgery, biological and biomedical science. He is also director, a Center for Regenerative Medicine and Stem Cell Research. He is also director, Center of Oncological Research in Surgery, scientific director, Juma Research Laboratories, and Hussein Ibrahim Family Chair, the Aga Khan University. He has authored over 300 manuscript, chapter, abstract, and articles. Welcome, sir.
बहुत शुक्रिया. अस्सलाम वालेकुम. Good morning. Back in Lahore, always a pleasure. Can we move this? Okay, all right. Dr. Ali Imran, कहाँ पर हैं? Doctor, I have one word for you: progressive. Progressive. See, it works. You know, I mean, I can look here and I can look at you, right? Okay. So Dr. Professor Nazim Islam has already given an introduction to this thing. So we're just going to move ahead and give a perspective of why really we need that. My last 20 years in Pakistan, I have, slowly my focus has been moving towards this whole aspect. This is my picture that I took from an airplane as I was landing in Karachi, which is beautiful, I don't think anybody else has taken this kind of picture. So some disclosures, there's no conflict of interest. Part of this research associates and assistants were supported by HEC grant. Aziz Sharif family, who made the Center for Oncological Research, they're also supporting it. And travel and lodging by PES conference organizers, thank you very much for doing that. If you look at it, if you look at the, on the right side, I have these societies. This is Pakistan Society of Basic and Applied Neuroscience. We have a conference next weekend. It's the, it's the first time we are moving out from Karachi and coming to Punjab. So I hope that you guys are aware of that. And this is the society that worked with the PES to make this thing. Our sister society is Pakistan Brain Tumor Foundation, which looks at from the patient's perspective on brain tumors. And then the Pakistan Academy of Neurological Surgery is focusing on education and teaching only. So just for to give the perspective, these are the two cases. I'm not going to go into detail. This is a GBM patient coming from Gilgit, and obtunded person. His son is in 30s with kids, and I said, okay, yeah, we can remove the tumor. We will go with chemo radiation therapy. It's going to be about 14-15 lakh for surgery, another 14-15 lakh for chemo and radiation and so on. He said, I want to take care of it. I said, you don't look like you can afford it. He said, no, I will sell my land and try to make try to get some money for it. So I said, look, we can do the welfare in AKU, but the rest of it is still about 15 lakh. ज़मीन कितने की बिकेगी? 12 लाख की बिक जाएगी. ठीक है, चलो. ज़मीन से करते क्या हो तुम? That's my sole source of income. तो मैंने कहा कि if I take care of your father and we do everything, we will give him on average 15 months of survival. If I don't do anything, it's 6 months of survival. 9 महीने की खातिर तुम जो है अपने बच्चों का मुस्तकबिल ज़ाया कर दोगे, because you'll be on the street. Give him comfort care. Now something like this, Ali Imran, and there are a lot of people from England and USA and Canada coming over here. We would never think about it. I mean, Asif Bashir goes and practices there regularly. We would never think about it like this. But this is what we have to do in LMIC until we get our things together. This is another patient coming from up north. Big tumor, resected very well, did not follow up for 6 months, for 3 years. I was supposed to come back in 6 months. Recurrence and then died. So these are the two main issues, affordability and access. Those are the two main issues. And that's why we started to focus on the unmet need for surgery in South Asia. The highest population is over here in India, Pakistan, China, and so on. And what we see is the cancer is going to keep on increasing over time. This is blue bars are the cancer. 50% of the world's population live on less than $2.50 a day. And because of that reason, about 150 million individuals undergo catastrophic expenditures, which leads to pushing them below the poverty line in about 100 million individuals. That's too much. And then, we have our wonderful government who's doing wonderful things for us, and they are giving us 0.16% of their budget for our health. We need to say thank you to them. And then that on top of situations like where we have proportion with no access, 99% in South Asia. This is what we're dealing with. Our per capita income, if you look at it over here, India and Pakistan, you see it over here, GDP per capita is over here. And if you put it together, I mean, just a context, ke liye, Singapore is like 79,000, Luxembourg is 135,000. Our population with insurance is so low. And then more than 22% are below poverty line. So these are the issues. The craniotomy costs about $6,000. So keep all that in mind. Yes, we do have things like that. AKU gives a lot of money. Shaukat Khanam is all free. Indus Hospital is free. But still, that's not enough. But what happens is that people like us, they go abroad, they get trained, and then come back, and they say, this is how we're going to treat brain tumors. That's not going to work. We're going to push a square peg in a round hole, and that's the wrong attitude. That's why we need to step back and think what we really need over here. We end up, think of the CAR T therapy. It's about $500,000. Can we afford that? 1.16% of that is going $500,000 CAR T therapy. It's impossible. This is gliadel wafers. It used to increase 1.3 months survival in GBM patients. And the cost of this is about $12,000, which is twice the price of total craniotomy. And these expensive gadgetries and whatnot. So I think we had to look at that, and that's why what we did, besides making the Pakistan Society of Neuro-Oncology, we made the Pakistan Brain Tumor Consortium, and I'm thankful to even Asif Bashir and other people from Lahore and other part of the country to come up with give the data that gave us a lot of answers, and then we came up with this supplement with Pakistan Brain Tumor Epidemiology. It showed us a lot of gap in our knowledge. Histopathology was different. The primary, the loss to follow-up was very high that we see over here, and so loss to follow-up was very high. And then socioeconomic, status was not represented appropriately. There were a lot of things that we saw. The metastasis that we see about 30% in HICs, over here it's only 2%, which is very amazing. We're looking into that. Now, this data, which is PB test, Pakistan Brain Tumor Epidemiological Study, is blue bar, and this US data is CB Trust. So what it showed that our patients are coming up early with tumors, brain tumors. Although our population is slightly different, but still does not explain that. And furthermore, what we saw that when we compared the PB test data with the CB Trust data, the male to female ratio is different in different tumors, but if you compare it, then you come up with a ratio which is more than 1, which means that there's a gender bias in managing brain tumors in Pakistan. We need to look into that. So those are the gaps that we saw. Big time, big issue, major issue. And this really was like amazing what we saw. About after your treatment, those patients that needed chemotherapy and radiation therapy, 64% and 55%. The surgeon had no idea what happened to them. They did the surgery and the patient is gone. Thank you very much, that's it, right? And this is unacceptable. About 60% of patients had to travel more than 50 kilometers. 20% had traveled more than 500 kilometers. The norm is about 30 to 40 kilometers. The time to surgery for high-grade gliomas, 72 days. So those are the issues. And then there's the issue of private sector and public sector. So we are moving from PB test to prospective PB test and then looking at the health economics. The research papers, there are more research papers coming from HIC, more research papers coming for diseases that affect HICs, less research papers for those diseases that affect LMICs. So we really need to move in that direction and think about innovation. So this is one of the innovation that we were able to figure out. This is the mobile MRI. It's something that you can push with your hand. You can train a resident to run it in half an hour. And we published a lot of papers on that one using that mobile. And we were the first one to use as an intraoperative MRI. It's unthinkable that you will have an intraoperative MRI in an LMIC, but we were able to do that. And if you look at the results from the 1.5 Tesla MRI and the ultra low field MRI, they're pretty much comparable. This is what a neurosurgeon needs. Now we are moving towards also using artificial intelligence for virtual biopsy. So that project is running on. We have done some good work in that one. Liquid biopsy, microRNA is what I'm focusing on. We have some excellent data that come up on that one. So what we need to do is look at these things that we can cut down the cost. Liquid biopsy, virtual biopsy, adopt essential and frugal techniques. Think about things like this, awake craniotomy. I started this thing up in 2015 in Pakistan. And the improvement of awake craniotomy versus GA is definitely there. And you need to follow that. with the Harvard group, I've come together. We have produced some policy recommendations. That's what our goal should be. After all these studies, policy recommendations to change the policy, and then educate and train. That's a problem. These two patients, they were sent by neurosurgeons for radiosurgery, and it just keeps going on. It never stops. I don't know what has happened in the medical school or in the training, that how come these neurosurgeons don't understand that these are not cases for radiosurgery. And then there is unethical practice that's going on among some radiosurgeon centers. They give cash to you. So, obviously there's a quick link that goes around. I'm not going to name that, but, at least I can start to say that. I didn't used to say that in the past. So we need to educate and train, and that's what we're developing guidelines. So we developed some guidelines which were published in the JPMA, Global Neuro-Oncology. This is all about brain tumors. And this is related to what we had over here. So in pituitary adenoma, we talked about the pituitary adenoma score, giant pituitary adenoma, and things like that. That has been published already. And then these guidelines. Now, these are the 4 points that I want to just mention. That neurosurgical management should be considered after endocrinologist review unless an emergency. So that's 1 point. So neurosurgeon should not just patient comes in and, okay, let's go for surgery. It has to go. And then, Dr. Najam will attest to that we always go through that route. Neurosurgical approach should be based on size and extent of tumor. Radiosurgery or commercial XRT, IMRT, things like that, should be vetted through pituitary tumor board. And then these guidelines, these guidelines, they are not final. We need your help. We need your feedback to keep on improving that. This is the team that has helped, and many more. And thank you very much.